we are going to decode the mechanics of failure.
Mm-hmm.
We're going to look at the engineering behind how doctors actually figure out your lungs are failing. Because it turns out, as I learned reading this, you can't just eyeball it.
No, not at all. You really can't. It's a detective story that takes place at the molecular level. You have to look at the invisible to understand the visible.
Right. And we're going to get into the physics of airflow, why breathing out is actually harder than breathing in when you're sick, which just blew my mind.
Yeah, that's a big one.
We're going to take a tour through the wreckage of a damaged lung, looking at emphysema, pneumonia, tuberculosis. And finally, we're going to talk about the machines, the iron lungs, and the weird chemistry of turning blue.
It's a fascinating journey. We're going from the...
So let's dive right in. The source material starts with this idea that diagnosing respiratory failure is tricky. It says respiratory insufficiency isn't just a feeling, it's a precise physiological state.
Right. And that's a crucial point to start with. In the past, or maybe, in a first aid context, you might look for signs of distress. Is the patient panting? Do they look anxious?
Sure, the obvious stuff.
The obvious stuff. But strictly speaking, those are symptoms, not a diagnosis.
Right.
To know for sure if the gas exchange system is failing, you need to look at the blood.
The toolkit.
The toolkit. Specifically, we need to measure blood gases and pH.
Okay, let's unpack this toolkit, because the text describes some pretty ingenious engineering here. We're talking about measuring three things: pH, CO2, and oxygen. Let's start with pH.
Well, pH is fundamental. It tells us how acidic or alkaline the blood is. And the body is extremely fussy about this.
Fussy is an understatement, right?
Oh, completely. Even a tiny deviation can be catastrophic. If your blood pH drops too low or goes too high, enzymes stop working, electrical signals in the heart get scrambled, the whole system just shuts down.
The source mentions a glass pH electrode. Now, I remember pH strips from high school chemistry, turning pink or blue. This sounds a little more high-tech.
It is, a lot more. Think of it as a miniaturized version of what you might find in a high-end chemistry lab, but it's been adapted for clinical speed. The core technology is a special type of glass that generates a tiny electrical voltage when it interacts with hydrogen ions.
Wait, so the blood touches the glass and the glass itself generates electricity?
Essentially, yes. The voltage it generates is directly proportional to the pH. You just read that voltage directly off a voltmeter. And the beauty of the modern version is that it's incredibly small.
You don't need a huge sample.
No, not a beaker of blood. You need mere drops.
And it's fast.
Minutes, which, in an emergency room where a patient is crashing is everything. You don't have time to send a sample to a lab across town and wait. You need to know right now if the patient is acidotic.
Okay, so that's acidity. But what about the gases? How do we measure carbon dioxide, CO2, dissolved in blood? The text says they use a glass electrode for this too, but with a twist.
Right. This is where the engineering gets really clever. They take that same standard pH meter we just talked about, but they wrap it in a disguise.
Disguise? What do you mean?
They create a tiny chamber. Imagine a thin plastic membrane, super, super thin. On one side is the blood you want to test. On the other side, inside the sensor, is a little solution of sodium bicarbonate.
Like baking soda solution.
Basically, yeah. Now here's the trick. CO2 is a gas, which means it can diffuse right through that thin plastic membrane. But the other stuff in the blood, the red blood cells, the proteins, the plasma, they can't. They're stuck on the outside.
So the CO2 sneaks through the barrier.
Exactly. It diffuses from the blood into the bicarbonate solution until the pressure is equal on both sides, until it reaches equilibrium. Now, when CO2 mixes with water and bicarbonate, it causes a chemical reaction that changes the pH of that solution.
Ah, okay. I see where this is going, since you already have a pH meter sitting right there inside the solution.
We measure the pH change, and thanks to a famous bit of chemistry math called the Henderson-Hasselbalch equation, we can calculate exactly how much CO2 must be present to cause that specific pH change.
That is surprisingly elegant.
Yeah.
So you're not measuring the CO2 directly, you're measuring the shadow it casts on the pH of the solution.
That's a beautiful way to put it. Yes, you are measuring the chemical footprint of the CO2. It's indirect, but it's incredibly precise.
Okay, so we have pH and CO2. The big one left is oxygen, PO2. How do we catch that?
This uses a different technique called polarography. It sounds a bit like something from an Arctic expedition, but it's actually about electrical polarity.
The text mentions a negative platinum electrode. That sounds pretty specific.
It is. We have a tiny piece of platinum, maybe 1 square millimeter in surface area, very, very small. And again, like with the CO2 sensor, it's separated from the blood by a thin plastic membrane.
The membrane seems to be the key.
Oh, it's crucial. It keeps proteins and other things from poisoning or clogging up the electrode's surface.
Okay, so we have this tiny platinum wire behind a shield. What happens?
We apply a negative voltage to that platinum, specifically a voltage that is more than negative zero point 0.6 volts. When you do that, something interesting happens electrochemically. Oxygen molecules that diffuse through the membrane hit that electrode and they react in a way that allows current to flow.
So no oxygen, no current.
Pretty much, yeah. The rate of the current flow is directly proportional to the concentration of oxygen. More oxygen, more current. Less oxygen, less current.
It's a direct readout.
A direct readout. If the blood is full of oxygen, the current is strong. If the blood is hypoxic, the current is weak. Simple as that.
And again, the text emphasizes that these aren't three separate clunky machines rolling into the room on carts.
No, and that's really the miracle of modern point-of-care medicine. All three of these, the pH electrode, the modified CO2 electrode, and the oxygen polarography electrode, are often built into a single, compact apparatus.
One drop of blood.
You take 1 drop of blood, you feed it into the machine, and boom, you get the full picture of the patient's respiratory status.
That's incredible. It allows for moment-by-moment tracking. You can literally watch the numbers change as you treat the patient.
Which is vital because, as we said at the start, things can change terrifyingly fast in respiratory failure. You need to know if your intervention is working now, not an hour from now.
Okay, so that's the toolkit. We know what is in the blood. Now we need to talk about the mechanics of getting the air in and out. This section in the chapter on the physics of expiration really, really surprised me.
How so?
Well, I always just assumed that if I'm having trouble breathing, the answer is to try harder. Push the air out with more force. But the source material says that's actually counterproductive.
It is. It's a classic case where your instincts are wrong. There's a phenomenon called maximum expiratory flow, and it's a hard limit, a physical ceiling.
Okay, let's define that. What is maximum expiratory flow?
It's the concept that after a certain point, no matter how much harder you push with your chest muscles, you cannot make the air move out any faster.
But why? That just defies logic. If I push a plunger harder, water shoots out faster. Why doesn't air shoot out of my lungs faster?
Because your lungs aren't rigid pipes like a syringe. They are soft, pliable, squishy tissues. When you exhale forcefully, you are compressing your chest cage. That puts pressure on the alveoli, the little air sacs, which helps push air out. That's the plunger part of your analogy.
It's pushing the air.
But, and this is the big but, that same pressure is also squeezing the bronchioles, the very tubes that the air has to travel through to get out.
So you're squeezing the air out, but you're also squeezing the exit shut at the same time.
Exactly. The source calls it the check valve effect. The external pressure on the outside of the airways causes them to collapse. So the harder you push, the more you narrow the tube. It just cancels itself out.
That's terrifying. It's like a Chinese finger trap for your lungs. The more you struggle, the tighter it gets.
That's a perfect analogy. And this is especially true when your lung volumes are low.
The text mentioned lung volume being a major factor here. Why does it matter how full or empty the lungs are?
Well, imagine the lung tissue as a complex network of elastic bands. When the lung is full and expanded, all those elastic bands are stretched tight. They are physically pulling the airways open from all directions.
Okay, like guy lines on a tent holding the poles up.
Yes, that's a great image. But as you exhale, the lung shrinks. The tension on those elastic bands relaxes. The pull holding the airways open just disappears. So the airways become much floppier and much more prone to collapsing under pressure.
So at the end of a breath, your airways are naturally unstable.
Correct. And if you add a lot of extra pressure from the outside by trying to force that last bit of air out, they just snap shut.
This brings us to the visual part of the source material, the flow volume curve. Now, obviously, our listeners can't see the graph, so we need to paint a picture for them.
Okay. Imagine a graph. The vertical axis going up and down is how fast the air is moving, the flow rate. The horizontal axis going left to right is how much air is left in your lungs.
So a healthy person takes a huge deep breath and then just blasts it out hard and fast as they can.
Right. In a healthy person, the curve shoots up almost instantly to a high peak. The source says more than 400 liters per minute. It's a really sharp spike. Then, as the lungs empty, the speed gradually slows down in a nice straight diagonal line until the lungs are empty.
So it looks sort of like a triangle, a steep cliff up, then a long straight slide down.
Pretty much, yeah. Now let's look at disease. There are two main ways this curve gets messed up. The first one the chapter talks about is constricted lungs.
The source lists things like tuberculosis, silicosis, kyphosis, of course, scoliosis, fibrotic pleurisy, a whole bunch of stuff.
Right, and what all these have in common is that they are conditions that physically restrict the lung from expanding. Fibrosis makes the lungs stiff like old leather. Scoliosis creates a cage constraint, the ribs can't move.
So the lung literally can't get big.
Exactly. The total lung capacity, TLC, and the residual volume, RV, are both reduced. So if you look at their flow volume curve, it has the same shape as a normal one, but it's miniature.
A tiny triangle.
A tiny triangle. They can't hold much air, so they can't blow much out.
Mm-hmm.
But the airways themselves aren't necessarily blocked. There's just less air to move to begin with.
Okay, that makes sense. Now for the second condition, airway obstruction. This is asthma, emphysema.
This is a completely different story. Here, the lung might actually be larger than normal because of air trapping, but the curve looks completely different.
Text describes it as having a scooped-out appearance.
Yes. Remember that long, straight, diagonal slide down in a healthy person? In an asthmatic, the flow shoots up a little bit, but then it just crashes. The line doesn't go straight down. It curves inward, creating a concave scoop. The speed drops off a cliff.
Because of that collapse we talked about.
Precisely. They start to exhale, the pressure builds, the airways collapse, and the flow is just choked off. They have plenty of air in there, but they can't get it out quickly.
The source mentions a physiological paradox here. It says it is much, much harder to expire than to inspire for these patients.
And that's critical to understand. When you inhale, you create negative pressure in the chest. You are pulling everything open. The airways naturally expand, so breathing in is relatively easy for an asthmatic.
But breathing out.
Breathing out requires positive pressure. Positive pressure squeezes. So the already inflamed airways just slam shut. That's why you hear wheezing primarily on the exhale. It's the sound of air trying to force its way through a collapsed tube.
And this leads to something called air trapping.
Imagine taking a deep breath and then only being able to let out half of it before you feel the need to take another one, then taking another breath on top of that.
You feel like you're going to burst. It would be panic-inducing.
That's what happens. The total lung capacity and residual volume actually increase. The lungs become hyperinflated. It's like an overfilled balloon that you can't deflate.
There's a clinical test mentioned here that puts a number on this. FEV1 versus FVC. Those are acronyms we should probably decode.
Right. So FVC is forced expiratory vital capacity. That's just the total amount of air you can force out after taking your deepest possible breath, the total volume.
Okay, total volume and FEV1.
FEV1 is forced expiratory volume in the first second. How much of that total did you manage to get out in just 1 second?
Okay, so it's a race. It's not just how much, but how fast.
Exactly.
Right.
In a normal, healthy lung, you can expel about 80% of your total air in that first second. It's a whoosh. 80%.
And an airway obstruction.
In severe asthma or emphysema, that number can drop to less than 20%.
Wow, 20%. So they might eventually get the air out, but it takes 5 or 6 seconds instead of 1 or 2.
Exactly. The total volume, the FVC, might eventually be normal, but the speed is gone. And since we breathe rhythmically, if you can't get the old air out fast enough before the next breath comes, you're in serious trouble.
This connects directly to the specific diseases the chapter covers. Let's start with chronic pulmonary emphysema. The text calls it a destructive process, which sounds ominous, and it puts the blame squarely on smoking.
It does. It outlines a very clear, very tragic chain reaction. It all starts with irritation.
Step 1, chronic infection.
Smoke irritates the bronchioles, but it also does something very specific mechanistically. The nicotine in the smoke paralyzes the cilia.
The little hairs that are constantly sweeping mucus out of the lungs?
Yes, the cleanup crew. Nicotine paralyzes them. So now you have excess mucus being produced because of the irritation, and the sweeping mechanism that's supposed to get rid of it is broken. The mucus just sits there and stagnates.
And the text says the macrophages, the immune system's other cleanup crew, get inhibited too.
So you're completely defenseless. This leads to step 2, obstruction. That stagnant mucus and the resulting inflammation start to plug up the smaller airways.
Which leads to the air trapping we just discussed. Air gets in during inspiration, but it can't get out past the plugs during expiration.
And this is where the permanent damage happens. Step 4, destruction. The alveoli are incredibly delicate. If you trap air and keep inflating them, stretching them day after day, year after year, eventually the walls break.
The source gives a staggering number. It says 50 to 80% of the alveolar walls can be destroyed.
Imagine a beautiful, complex honeycomb. Now imagine smashing most of the internal walls of that honeycomb so it's just one big, hollow, useless cavern. That's an emphysematous lung.
And that sounds obviously bad, but why is it bad physiologically? I mean, less wall means less surface area for gas exchange?
That's the first problem, yes. A huge loss of surface area. But you also lose something else that's just as important, the capillaries.
The blood vessels are embedded in the walls.
Right. If you destroy the wall, you destroy the road the blood travels on. This leads to a massive increase in resistance to blood flow, which causes pulmonary hypertension.
High blood pressure in the lungs.
Think of it as a citywide traffic jam. You have the same amount of blood trying to push through a fraction of the available vessels. The pressure skyrockets.
And that puts a huge strain on the pump.
The right side of the heart. It has to push harder and harder against that incredible resistance. Eventually, it just wears out and fails. Right-sided heart failure is a very common end-stage consequence of emphysema.
That is just a brutal domino effect.
Yeah.
Smoke, mucus, trapping, wall destruction, vessel destruction, heart failure.
It's a slow, progressive, suffocating cascade. And the patient experiences what the text calls air hunger for years.
Let's pivot to something that hits much faster, pneumonia. The text defines this as an inflammatory condition where the alveoli fill with fluid and blood cells.
Yeah, this is an acute process, usually caused by bacterial pneumonia, often from pneumococci bacteria. The infection starts in the alveoli, and the pulmonary membrane, that super thin barrier, becomes inflamed and porous.
And porous means leaky.
Very leaky. Fluid from the blood, red blood cells, white blood cells, they all just pour out of the blood and into the air sacs.
The text uses the word consolidation. That sounds solid.
It is. A consolidated lung isn't an air-filled sponge anymore. It's a solid block of fluid and cellular debris.
So obviously you can't breathe with a solid block of fluid in your lung.
No gas exchange can happen in those areas. But here's the kicker. Blood is still flowing to those areas.
And that's a huge problem.
It's a huge problem. This creates what we call a physiological shunt.
Let's break down the map the source gives here because it's really specific and it makes the point so clearly.
Okay. So blood passing through the healthy, aerated part of the lung gets fully oxygenated. It leaves about 97% saturated with oxygen.
That's good. Bright red blood.
Right. But the blood passing through the consolidated, fluid-filled pneumonia part, it picks up absolutely nothing. It stays at venous levels, about 60% saturated.
So you have two streams of blood heading back to the heart. One is bright red and oxygen-rich at 97%, and the other is dark and oxygen-poor at 60%.
And in the left side of the heart, they mix. The result is an average. The source calculates the final aortic saturation drops to about 78%.
78%. That is incredibly low. That's severe hypoxia.
It is. And that's just from that mixing effect. It shows that even if half your lung is working perfectly, the other half can drag the whole system down by diluting the good blood with bad.
Now, compare that to atelectasis. This is lung collapse. The text describes two main causes. One is airway obstruction, similar to what we've discussed, but leading to a total collapse.
Right, say a big mucus plug or, a tumor completely blocks a major bronchus. No more air can get in.
But there was air in there before the block, so where does that trapped air go?
It gets absorbed into the blood. The blood keeps flowing past those trapped alveoli, and it just strips the oxygen and nitrogen out. Within minutes to hours, the air sac is empty, and because the lung is so pliable, it just shrinks down on itself. It collapses.
The source mentions massive collapse, which sounds awful.
It is, and it can create a powerful vacuum effect. It can actually pull fluid edema out of the capillaries to fill the collapsed space.
But here's the really surprising part. The text says that despite a massive collapse of an entire lung, the oxygen desaturation is often only mild. Wait a second, we just said pneumonia, which fills the lung, causes severe hypoxia down to 78%. Why does a collapsed lung, which has no air at all, only cause mild hypoxia?
This is the body's vascular safety valve. It's a brilliant, brilliant protective mechanism.
Okay, how does that work?
When the alveoli in one area collapse, they become hypoxic. There's no oxygen there. The blood vessels in that specific area sense the lack of oxygen, and they constrict. They clamp down hard.
They close the road.
Exactly. They divert the traffic. The resistance to blood flow in the collapsed, useless lung increases massively. So the blood naturally takes the path of least resistance. It goes to the other, ventilated lung.
The healthy lung.
The source gives the ratio. Blood flow to the collapsed lung can drop from, say, 56 of the total cardiac output to only 16.
So the body effectively quarantines the broken lung. It's stops sending blood to a place where there's no air to pick up.
Yes, it knows not to waste blood on a dead end, so you don't get
Yeah.
that shunting effect we saw in pneumonia. You don't have all that 60% saturated blood mixing in and poisoning the system. Most of the blood goes to the good lung, it gets fully oxygenated, and you stay relatively pink.
That is just so clever. The body is smarter than we give it credit for.
It saves your life.
There's another cause of atelectasis mentioned, which I think is famous in the context of premature babies, a lack of surfactant.
Yes, hyaline membrane disease, or what we now call respiratory distress syndrome.
What is surfactant, really?
Well-
We hear the word a lot, but what's the physics of it?
Okay, think of the alveoli as millions of tiny wet bubbles. Bubbles have surface tension. The water molecules on the surface want to stick together and shrink the bubble into the smallest possible shape.
Right.
Surfactant is a substance, a detergent really, that gets in between the water molecules and breaks that surface tension. It makes the water wetter, less sticky. It prevents the bubble from collapsing on itself at the ends of every exhalation,
The text says without surfactant, surface tension becomes 2 to 10 times normal.
which is an immense force at that microscopic scale. It's strong enough to snap the alveoli shut or literally suck fluid out of the capillaries to clear the space.
So for a premature baby who hasn't started making enough surfactant yet,
Every single breath is a battle against physics. Their lungs want to collapse completely between every breath. It's utterly exhausting, and they just can't keep it up.
moving on to asthma. We touched on the flow curve, but let's look at the actual mechanism. The text calls it spasmodic contraction of smooth muscles.
It's a spasm. The bronchioles, the small airways, are wrapped in tiny rings of muscle. In asthma, those muscles clamp down violently.
And it's driven by allergies in a lot of cases.
In about 70% of younger patients, yes, it's an allergic hypersensitivity reaction.
The chemistry here is wild. The source says pollen or some other allergen meets IgE antibodies, which are attached to mast cells in the lungs. And then boom!
It's a chemical explosion. The mast cells degranulate and release a whole cocktail of nasty chemicals. Histamine, leukotrienes, bradykinin, eosinophilic chemotactic factor.
That just sounds like a recipe for disaster.
It is. These chemicals do three things simultaneously. One, they cause that violent muscle spasm. Two, they cause localized edema, which is swelling of the airway walls. And three, they trigger the secretion of thick, sticky mucus.
So the tube gets squeezed by muscle from the outside, swollen shut from the inside, and clogged with slime all at once.
Triple threat. It's no wonder it's so hard to breathe. And over years, this constant difficulty in exhaling leads to a permanent change in the person's body shape.
The barrel chest.
Yes. Because air is constantly being trapped, the chest cage expands and gets stuck in an inspiratory position. The person looks like they're holding a deep breath forever.
And briefly on tuberculosis, this is a different beast entirely. It's not a spasm or an allergy. It's an invasion.
It is, by the tubercle bacilli. And the body's reaction is fascinating. It's a containment strategy. Macrophages, the white blood cells, invade the infected tissue and wall off the lesion with fibrous tissue.
That's the tubercle that gives the disease its name.
Right. It's essentially a tiny prison for the bacteria.
Yeah.
But this walling off process involves fibrosis scarring.
And scar tissue doesn't stretch. It's not functional.
Exactly. So in the late stages of TB, you have this widespread fibrosis throughout the lungs. It reduces the amount of functional lung tissue. It thickens the respiratory membrane, which makes diffusion harder. And it makes the entire lung stiff. It just dramatically increases the work of breathing.
So we've covered the diseases. Now let's talk about the consequences. Hypoxia, low oxygen. The source classifies this into different categories. It's not just a case of not enough air.
No, the why matters a great deal because the treatment depends entirely on it.
Let's look at oxygen therapy. We all assume patient has low oxygen, give them oxygen. But the text says it's not always that simple.
It evaluates the efficacy of oxygen therapy for the different types of hypoxia, and the results are pretty stark.
Okay, let's take type 1. Atmospheric deficiency, like being at high altitude, or hypoventilation, just not breathing enough.
Here, oxygen therapy is 100% effective. You are correcting the core problem completely. If the problem is low oxygen coming in, adding more oxygen to the mix fixes it. Simple.
Type 2, impaired membrane diffusion. There's like the fibrosis we just talked about in TB. The wall is too thick for oxygen to cross easily.
Here, oxygen is still highly effective. You have to think about diffusion gradients. Normally, the oxygen pressure in your alveoli is around 100 millimeters of mercury. If we put you on pure oxygen, we can drive that all the way up to 600.
That's a huge pressure difference.
It's a massive pressure gradient. And that massive pressure literally pushes the oxygen through the thickened wall. It forces its way across. So it helps a lot.
But then we get to the other types. Transport deficiency, like anemia, or problems with tissue capability, like poisoning.
Here, oxygen therapy is of very limited value. Take anemia. The problem isn't that the blood can't get oxygen from the lungs. The problem is there aren't enough trucks, red blood cells, to carry it away to the tissues.
What?
You can supersaturate the few trucks you have, but that doesn't solve the fundamental problem that you need more trucks on the road.
And with cyanide poisoning.
That's inadequate tissue capability. In that case, the cells themselves have been poisoned. Their metabolic enzymes are blocked. You can deliver all the oxygen you want to the cell's doorstep, but the cell can't open the door and use it. The oxygen is useless.
That's a chilling thought. Starving for air in a room that's full of oxygen.
It is. It shows the chain has to be intact from the air all the way to the mitochondria.
This leads us to the most visible sign of respiratory failure, cyanosis, the patient turning blue.
The blue skin. A very dramatic sign.
But the text has a huge warning here. Cyanosis is deceptive. It's not a reliable indicator.
Not at all. It is entirely dependent on the absolute amount of deoxygenated hemoglobin in the blood.
Hemoglobin is the protein that carries oxygen. When it's full of oxygen, it's bright red. When it's empty, it's a dark blue-purple color.
Correct. And the magic number, according to the text, is 5 grams. You need 5 grams of deoxygenated hemoglobin per 100 milliliters of blood for your skin to look blue.
Okay, 5 grams. Why is that number so important?
Because of the counterintuitive examples it creates. Let's take someone with severe anemia. They might only have 6 or 7 grams of hemoglobin total in their blood.
A healthy person has maybe 15.
Right, around 15. So if this anemic person is severely hypoxic, say half their hemoglobin is empty, that's only 3 or 3.5 grams of deoxygenated hemoglobin. That's less than the 5-gram threshold.
So they never turn blue.
Almost never. They could be dying of hypoxia, literally suffocating at the cellular level, and they will stay pale or pink. They just don't have enough total pigment in their blood to turn blue.
That is a dangerous red herring for a doctor.
Conversely, look at polycythemia. This is someone with excess red blood cells. Maybe they have 20 grams of hemoglobin. Their blood is thick with it.
Okay.
Even if they are breathing relatively well and oxygenating most of it, if just a fraction of that huge amount loses its oxygen, they hit that 5-gram threshold easily.
So they look blue all the time, even when they're not that hypoxic.
They might look cyanotic even when they're feeling fine. So
Yeah.
the blue color can be a false alarm in polycythemia and a completely missing alarm in anemia.
That really reinforces why we need those blood gas measurements we started the show with. You absolutely cannot trust your eyes.
Precisely. You have to measure.
Let's talk about the other side of the gas equation. Carbon dioxide, hypercapnia.
Excess CO2 in the blood.
How does this relate to hypoxia? Do they always happen together?
Usually, yes. In the most common scenarios, like hypoventilation, where you're just not breathing enough, you aren't getting O2 in, and you aren't letting CO2 out, so both go bad at the same time.
But there's a nuance in what the text calls diffusion diseases.
Ah, yes. Remember the thickened wall from fibrosis or edema? CO2 is a very different molecule than O2. It is much more soluble in water. It diffuses about 20 times faster than oxygen.
20 times. That's a huge difference.
It's massive. So if your lung membrane is thickening, oxygen struggles to get in long before CO2 struggles to get out.
So you'll be hypoxic, but your CO2 levels might be totally normal, or even low because you're hyperventilating.
For a while, yes. Hypercapnia is a very Lee-stage ominous sign in diffusion diseases. If the CO2 starts climbing, you know the lung damage is incredibly severe.
And what does high CO2 feel like? The text lists symptoms based on the pressure levels.
At a PCO2 of 60 to 75 millimeters of mercury, you get dyspnea, that intense feeling of air hunger. You feel like you just can't get enough air.
And if it gets higher?
From 80 to 100 millimergy, it leads to lethargy. You get sleepy, semi-comatose. It acts as a narcotic.
And over 100.
Anesthesia and death. CO2 effectively drugs you. It suppresses the respiratory center in the brain, which creates a vicious cycle. The more CO2 you have, the less your brain wants to breathe, which means you retain even more CO2.
And you just drift off.
It's a quiet respiratory death.
You mentioned dyspnea. Air hunger? The text says this is partly a state of mind, which is fascinating.
It calls it neurogenic dyspnea. Dyspnea is the mental anguish, the sensation of not being able to ventilate enough to satisfy the demand, but it can be triggered purely emotionally.
Like a panic attack.
Exactly. You can have perfect blood gases, normal O2, normal CO2, but your brain is screaming, "I can't breathe." The text mentions that some people have a psychological fear of not being able to receive a sufficient quantity of air, especially in crowds or small spaces, even when there's plenty.
So the sensation is completely real to them, even if the physiology is fine.
And conversely, you can train yourself to suppress it. Free divers, for example, can hold their breath long past the point where a normal person would panic, despite having screamingly high CO2 levels.
Finally, we have to talk about the machines. Artificial respiration. The source contrasts two main types, the resuscitator and the tank respirator.
The good old iron lung.
Let's start with the iron lung because it's such an iconic and kind of terrifying image. How does it actually work, physics-wise?
It works by mimicking the way we naturally breathe.
Which is by negative pressure.
Exactly.
Yeah.
When you decide to inhale, your diaphragm drops and your ribs move up and out, which creates a partial vacuum in your chest. Air then rushes in to fill that void.
So the iron lung creates a vacuum on the outside of the body.
That's right. The patient's whole body is inside the tank with just their head sticking out. A big leather diaphragm at the end of the tank moves back and forth. When it pulls back, it lowers the pressure inside the tank.
It sucks on the body.
It pulls the chest wall outward. That expands the lungs passively, and air rushes in through the nose and mouth, which are outside in normal room air.
So it literally pulls the breath into you.
Yes. And then the machine creates positive pressure in the tank to push the chest down and cause a passive exhalation.
Now, contrast that with a resuscitator. This is what we see in hospitals today, the modern ventilator.
This is positive pressure ventilation. This forces air into the lungs. You put a mask on the patient's face, or more commonly, an endotracheal tube down their windpipe, and the machine pushes air in.
It blows the lung up like a balloon.
Right. It's the complete opposite of natural breathing.
And the text highlights a major, major danger with this positive pressure method. Something about venous return.
This is absolutely critical. We tend to think of the heart and lungs as separate, but they are mechanically linked inside the chest.
How so?
When you breathe naturally with negative pressure, that vacuum in your chest doesn't just pull air in, it also helps pull blood into the big veins and into the heart. It aids circulation.
It sucks blood toward the heart.
Yes. But when you use a positive pressure machine, you are pressurizing the entire chest cavity. You are squeezing everything inside.
So you're squeezing the heart.
You are squeezing the great veins that are trying to bring blood back to the heart. You're creating a roadblock.
So less blood gets back to the heart.
And if less blood comes into the heart, less blood can be pumped out. Cardiac output drops.
The text mentions lethal levels.
It warns that continuous exposure to high positive pressure, it says more than 30 millimeters of mercury for more than a few minutes, can reduce cardiac output to lethal levels.
Whoa. So you could literally kill the patient by inflating their lungs too hard.
You can suffocate the heart while trying to ventilate the lungs. It is an incredibly delicate balance. Modern machines have all sorts of pressure limits, usually around 12 to 15 centimeters of water to prevent this, but the risk is inherent to the physics of the method.
That is a truly sobering realization. We started this deep dive talking about the simple unconscious act of breathing, and we've ended up seeing just how complex and precarious the whole system is.
It really is. It's a marvel of engineering. All these gradients, pressures, surface tensions, chemical sensors, all working in perfect harmony 15 times a minute without us even noticing.
So, after all that, what's the big takeaway for you from this deep dive?
For me, it has to be the body's own compensation mechanisms. The way the lung intelligently shuts down blood flow to a collapsed section to save the oxygen levels for the rest of the body. Or the way the chemical sensors in the blood vessels are tuned to fractions of a volt. It's a system that is brilliantly designed to survive, even when parts of it break.
And for me, it's that 5 grams rule for cyanosis.
Mm-hmm.
The idea that you can be dying of a lack of oxygen, but stay pink because you're anemic, or turn blue when you're basically fine because you have too much blood. It's such a powerful reminder that in medicine, things are almost never what they appear on the surface.
Always look at the data. Never trust your gut completely.
Here's a final thought to leave you with. We talk about how the body shuts down blood flow to damaged parts of the lung, that vascular safety valve. It makes you wonder, what other systems in our body have these hidden kill switches or rerouting protocols that kick in without us ever knowing, making life or death decisions on a microscopic level while we're just sitting here waiting for a podcast to start?
That is a thought worth pondering.
Take a deep breath, everyone, and really, really appreciate it. Thanks for listening.
Goodbye.